Going to get started. So thank you for coming. This is the last session of the day. And now I'm presenting Dr. Counard. She's the State Medical Officer for the Illinois Department of Public Health, and her prior positions include Director of Skokie Municipal Health Department, Assistant Medical Director for Emergency Preparedness and Communicable Diseases, and Cook County Department of Health, along with 7 years as a family physician with the United States Navy. She has extensive experience with legislative and public policy issues, such as improving access to healthcare, tobacco control, food safety, and communicable disease control. And Dr. Counard also serves on the board of the UIC Public Health Executive Board. Sorry. Thank you, Dr. Counard.
Thank you. Can you hear okay with this microphone? Can you hear me okay? Okay, good. I'm the last talk and a long day between you and going home. So I will try to make this a little bit lively, but also thank you all for being here today and for coming to the summit. We all really appreciate you making that effort and gaining this knowledge and sharing your experiences with us. I was asked, this is a change of pace because most of the global dangerous diseases are not antibiotic resistant. And so what Shannon asked me to do is, we've all been through pandemics recently, and to talk about how they emerge, what might be done to prevent them, how can we identify them. And I do have a few slides at the end talking about, well, it didn't go so great this time, right? So what can we plan for the future, what's being done? It's a big overview. Any of the individual points that I'm making could be a full hour-long talk, but I'd be happy to hear, and I'm hoping we have some time for everyone to share some of your experiences through what we've been through over the last 3 years. So I don't have any conflicts of interest. All IDPH presentations, we should just talk a little bit about our organization, work for the Illinois Department of Public Health. And I came on board in August 2020 to help with the pandemic, I should say, COVID-19, specifically to work with long-term care facilities. Many of you might have heard me on our weekly and then bi-weekly. More recently, we also have Tom Room here with us, who's from IDPH, who's been doing a lot of those calls as well, and our beloved Hectone infection preventionist, who really led the charge from the beginning of the pandemic up until October of last year, when they transitioned into working more on multi-drug resistant organisms. So I came on board in August 2020 to work on congregate settings, prisons, shelters, and long-term care facilities specifically. In any event, IDPH, our mission is to protect the health and wellness of the people of Illinois, obviously, through prevention, health promotion, regulation, and the control of disease and injury. Our agency's been around since 1877, and it's one of the state's oldest agencies. That makes sense. There were a lot of infectious diseases in 1877. There was a need for a state health department. And of course, we have many programs beyond infectious diseases, including food and water and drug testing, vital records, and so on. So this is what I'm, as I said, planning to talk about today, just the U.S. burden of infectious diseases, the factors that contribute to the emergence of infectious diseases, our pandemic preparedness. We'll look at a few case studies and then talk about challenges and solutions. In preparing for this talk, I found out, which I didn't realize, that 1850 was the first time the United States decided to compile what everyone had died from in the prior year. And so it's an interesting read. The physician who wrote this said, people care more about their stocks and their stock values than what people are dying from in this country. It's been very hard to get this information. Does this sound familiar? Probably sounds familiar to everyone in the room, right? And so that was from 1850 up until now. But at that time, the 10 leading causes of death were all infectious diseases. They were all infectious diseases. But not too long after that, there was the discovery of microorganisms as the cause of many serious diseases. And that led, of course, to significant public health actions like sanitation and hygiene, the development of antimicrobials, implementing universal childhood vaccination, and then, of course, animal and pest control. When you think about it, 1850 wasn't really all that long ago. So the impact of public health measures. You can see that for all of the actions that were taken after we realized that there were microbes that were causing a lot of diseases, there was a significant reduction over time in infectious diseases causing mortality in the United States. And that by, around 1950, chronic diseases had become the leading cause of death. But there's a lot of year-to-year variation. Some years flu was much worse than others. And we've had some pretty bad things happen in the meantime, too. One being the 1918 influenza pandemic, killing approximately 500,000 Americans. HIV/AIDS pandemic, with since 1981, 700,000. People are still dying every year from HIV/AIDS in the United States. And then, of course, COVID-19 pandemic, which we all just are living through, 1.1 million. But I think that it's good to see it's not been that long that we've been, in 1900 or thereabouts, states were getting health departments. Then we had the chlorination of water, plague, controlling rats, penicillin, and so on, getting vaccinations out there. All of these measures have been very important in reducing the risk of communicable diseases, but they still exist and they can still cause a great number of deaths. So here we are, 2018, 2019, usual pattern, top 10 leading causes of death. Flu and pneumonia is the only one that's on there. It's number 9. And then COVID-19 hit. And we had, this is from the Census Bureau, who I don't really think of as being rogue or anything, but I was interested by their title that, the pandemic caused the largest jump in deaths in 100 years. And so that 19% increase you can see there is the number of deaths. And then over on the right is the blue line is 2020 to 2021 with all the actions that were being taken. And then we have 2018, 2019. So consistently since 2010, all the death graphs have looked like that 2018, 2019 until the pandemic hit. And then we had this huge increase in deaths. And you can see there in the middle, I thank goodness we got vaccinations, right? That's what really saved us, was to get the vaccinations and get those into everyone, because then there was a steep drop off in deaths. And that was something, of course, they didn't have back in 1918. So now we have an infectious disease as the 3rd leading cause of death. Last year it was the 4th leading cause of death, but in 2020, COVID-19 was the 3rd leading cause of death, an infectious disease. We hadn't seen anything like that since before the 1950s. So what is an emerging infectious disease? I feel like I'm singing to the choir, as they say here. Newly appeared in a population or have existed but are rapidly increasing in incidence or geographic range. Well, I looked at all these and I've been alive for all of them, right? And have been practicing medicine for most of them. So I was in medical school when HIV came upon the scene. So this, when you think about it, that's quite a few diseases that have emerged during our lifetimes. And some of them have caused pretty significant illness and death. I did read this article by Dr. Fauci as part of preparing for this, and I liked how he and his colleague, Dr. Morens, organized the major categories of emerging infectious diseases. New diseases that are in humans for the first time, such as SARS-CoV-2, MERS, SARS, HIV. Re-emerging infectious diseases, diseases that are known that are appearing in new locations. West Nile virus, for instance, when it came into the United States in 1999, or even the Zika virus, which hadn't really been seen in this area until a few years ago, Or it could be a disease that's become a pathogen that's become resistant to antibiotics, like methicillin-resistant Staph aureus. It could be deliberately emerging infectious diseases. Unfortunately, we did have that episode with anthrax. Or accidental. For instance, now there's a strain of polio out that in the world that was a vaccine strain that has now caused some disease in individuals. So obviously it's a global concern. I think no one would argue with the idea that diseases that are emerging anywhere in the world now are a problem for the United States because they can be here within a day. And this is the map of March 3rd, 2020, where COVID had been detected. So, I mean, I was struck by that again, looking at it. March 3rd, we weren't prepared. We were just kind of gearing up here in the United States to think about maybe COVID or coming to this area, SARS-CoV-2. But look how far it had been. And the larger the circle, the more cases there are. So considering that we get something like 300 million people visiting every year here, we were a little bit behind the game at this point. So the problem, of course, with new infections is that they can get around, as I said, millions of people can be affected. There may not be a treatment, and we may not be able to contain it. Anybody, I think, looking at this map would think, we're probably not going to have a good time with this at this point. And this is just in March. There are specific factors, of course, that precipitate an emergence and also transmission. So it has to be an introduction of an agent into a new host population that hasn't experienced it before. And then establishment and dissemination. So anything, there are many different things I'm going to talk about them that can facilitate one or the other of these two-step processes and promote disease emergence. And I love this quote from Dr. Morse in Factors in the Emergence of Infectious Diseases from Emerging Infectious Diseases that most emerging infections and even antibiotic-resistant strains of common bacterial pathogens usually originate in one geographic location and then disseminate to new places. Here's the list of factors that contribute to the emergence and spread of infectious diseases. And this has been something that's been thought about quite a bit. There's a lot of work being done on this area, of course. Sometimes we've felt that in this country that we had conquered infectious diseases, so there was less attention being paid than other times. But I think at this point, most people are going to be quite concerned about diseases for some time that are emerging anywhere in the world. Ecological changes, agriculture, human behavior, international commerce and travel, technology and industry, microbial adaptation and change, the breakdown of public health measures, poverty, inequality. I'm not going to cover all of these. War and famine. I did include here a picture from 1918 ship with troops. You know, the 1918 influenza pandemic, we think, started in the US and was spread around the globe because we were at war and it went with our troops. And if you look at any of the graphs of how quickly it spread around the globe in a matter of weeks. And that was before airplane travel. So our troops went. We didn't really want to acknowledge in the United States that there was a problem because we were at war and we didn't want to seem like we had any weakness. You know, I mean, it was kind of political then too. There were municipalities that had very large pro-war gatherings where there was big outbreaks and so on. So war can definitely contribute, and we contributed back in 19 during the war as far as helping to spread the 1918 influenza. So quick check for learning, because this is supposed to have CME. Public health actions in the late 1800s and early 1900s substantially reduced the risk of dying from infectious diseases in the United States. True or false? Newly emerging or re-emerging infectious diseases continue to pose a global threat. I figured it was the end of the day. We were going to ask real hard questions here. Human actions and behaviors on a local and global scale contribute to the emergence and spread of infectious diseases. True. All true. So let's just talk about a few of these. Ecological changes and agricultural development. I think this has been covered in some of the other talks today, but frequently these are identified as factors in the emergence of disease. People are placed in contact with a natural reservoir of a host where the disease is already present. So either because they've increased proximity or they've changed the conditions in that area to favor an increase in a population or microbe or its natural host. So anything that can increase our opportunity to be exposed to things we never were before, or to make it that the animals or vectors that have those diseases, we make it so that they are happier and more of them are abundant and they're living near us. Those are the things that can lead to spread of infectious diseases. Zoonotic, arthropod-borne. And so here's just some examples. If you have water from a dam or irrigation that's standing, you can have more mosquitoes in the area. Climate change with a milder winter. We feel that might have led to the hantavirus outbreak that was out in the Southwest previously. Deforestation. Wild animals still have to live somewhere. Now they've moved in with you and your pigs and chickens and so on. So you're in contact with them. And then agriculture, consolidation of farms. These big, massive animal farms can lead to transmission of disease in that area. And there have been instances of bats with a disease eating fruit that falls to the ground, or they're living in the same area where pigs are. The pigs are eating the fruit. They get the virus. It's then transmitted to the people who live there as well. So this type of transmission and interactions occurs rather frequently, actually. So I liked this graph quite a bit too, just showing. And we're going to talk about examples of how this can all work. Most people aren't really in contact with wild animals. There are some instances of hunting wild animals and so forth, but we're much more likely to be in contact with domestic animals. But the domestic animals are out and about in the world, and they can have contact with the wildlife that's out there as well. Ducks coming and landing and with the chickens and so on. So bats, rodents, and ducks are important reservoirs of viruses in particular that can impact humans negatively. And the trouble is that similar to a cold, we think that those are coronaviruses from earlier times that maybe cause more severe illness in humans, but we're not that impacted if we get a cold. These animals may have been living with these viruses for a long time, so they may not be tremendously sick. However, if the virus is spread to another animal or ourselves, we may not have that same kind of a milder illness, and it could be much more serious. So I already talked about West Nile virus, coronavirus, Ebola, Marburg, hantavirus are all thought to be transmitted in this way. With the interactions between ourselves, livestock, wild animals, and the vectors out in the community. Another problem is crowding of people. More and more people are living in large, major global population now lives in high density cities. Rural, if you're in a rural area, if there's an outbreak of a disease, it's affecting a smaller number of people. But if they bring that then into larger urban centers, then that can be a problem where there's a lot more transmission. So diseases that maybe in the past might have been small and localized are going to have a much bigger impact because they're coming to urban centers. Crowding, not only in homes, but sporting venues, houses of worship, and so on, beaches, airports, can lead to infectious disease transmission, as we saw with COVID. As well as then now that we have these large urban centers, there's a lot of transport between the urban centers, so that can lead to transmission of disease as well. And then here's an image showing the impact of urbanization, and again, showing how we are encountering more likely to encounter or modify the environment where wildlife is. So there's more likely to be human wildlife interactions. But then also because of the way we've constructed our environment, the mosquito may be more popular, it might be able to live there more easily, and so on. Then I thought this was interesting too. That top map is from 1933, showing airline travel for the year, the routes. And then 2020 is on the bottom. It's hard to imagine that we would think anything would stay any place. It starts out with that level of travel between parts of the world. So anything that's spread person to person is going to be pretty easily spread through air transport at this point. And what we saw back in 19, it was by ship. Now we have air. And so it's much more, it's much faster. Also, it's so fast that if they're bringing goods in containers that have insects and so on, they can still be alive by the time they get to the United States. And that brings us to international commerce with expanding global trade markets that have increased the potential for rapid dissemination of pathogens. Packaging can have insects, ship ballast can have bacteria, slugs, snails, and so on. And then the trade of live plants, animals, and animal products. I didn't realize until I was preparing for this talk that we imported 23 million animals from other parts of the world during that 4-year period between 2010 and 2014, which is the last time data has been available. Parts, samples, products, and it was bats, primates, and rodents, which I already said were the ones that were most likely to have diseases of concern to humans. So one area that is being worked on in the world is to try to decrease the U.S. consumption of wildlife and U.S. interest in wildlife as part of trying to limit the spread of diseases and also to preserve the natural world. Think of the U.S. having 23 million animals that were taken from the wild somewhere else in the world and brought here. So I did talk a little bit about how West Nile virus came in 1999. It wasn't identified ever exactly what introduced it, but the outbreak started in New York by the 2 international airports. And then once it was introduced, West Nile virus became quickly spread to our native Culex mosquito species. 2003 U.S. monkeypox outbreak. Pet prairie dogs were kept with rodents from Ghana who had monkeypox, it turned out, gave it to the prairie dogs, who then, if you remember, gave it to their owners. Now, there wasn't much or any human-to-human spread at that time. And then Vibrio parahemolyticus is a pathogen endemic in shellfish in the U.S. Pacific Northwest. But then, ships have likely spread that to other parts of the United States, Europe, and South America in their ballast because it's now showing up in other parts of the world in ships that have been in that area. So the international commerce is an area of concern. And, many of these animals and packages and so forth, there's not enough people to really look at all of that and try to make sure that we don't transmit either vectors or disease itself between parts of the world. Technology has of course been very helpful to us as well, but we do see new diseases sometimes arise with our technology. Legionnaires from water cooling towers, for instance, and that's a cooling tower on the right-hand side. That's from the CDC. That's the same color as the CDC building, so I kind of wondered if it was one of theirs, but I'm just thinking. Toxic shock syndrome from superabsorbent tampons, if you remember that. E. coli. Our food production can lead to transmission of disease. I didn't have a chance to look up how many cows get made together, but it's a huge number of cows that go into any package of ground beef. So the likelihood that there could be a contaminant and then their ability to trace it back and find out where it might have originated is very difficult. because of how we're producing food in this country. But if you remember that E. coli O157H7 causes hemolytic uremic syndrome, and it was related to, contaminated beef. And then there's inadvertent transmission through blood. You've probably heard about the fungal meningitis in the news recently. People who've gone down to Mexico to a couple of clinics had epidurals and were inadvertently given a fungus that they have to be followed up on. And so that's been in the news lately. And then, of course, microbial adaptation is another area that's of interest. Because most of the diseases of concern that are going to cause really big outbreaks, like we saw with COVID, are viral, I'm going to be speaking more about how the viruses make sure that they have how they've adapted, and they're actually pretty interesting. This first point, genetic instability, I thought was interesting. They're very sloppy. Flu and coronaviruses, we make sure when our cells divide that they're the same. We try not to have them be any different. So there's all kinds of mechanisms to make sure that there's an exact replica produced, but they don't. They're very, very sloppy, and really they're described of as more like a swarm of all somewhat different variations. And so that is how they can, they've been around for millions and millions of years. That's how they can invade other hosts, because maybe if you encounter them, one or the other of them may have made an adaptation that would allow them to infect you. Also, tropism, the ability to enter a cell. We have all these receptors on our cells that viruses can attach to enter into the cells and then take over the mechanism of the cell so that it produces more viral particles. There's multiple different receptors that viruses can attach to, and many of those receptors are the same as our other mammalian or non-human animals. So the possibility that a virus that can infect an animal, especially a vertebrate, could then develop that ability to infect a human is pretty high, actually. And one of the things, this is again from Dr. Fauci, that he pointed out on here, is that the SARS-CoV and CoV-2 viruses enter human cells through the ACE2 receptors, and those are the same as the receptors on many non-human species. So it's not surprising that we would be infected by a virus we haven't experienced before in the human population. They can circumvent the immune response. We see that with HIV and influenza. We need to get a new flu shot every year because the flu virus shifts. Sometimes it drifts. So it changes enough that we're not able to recognize it. And we found that with coronavirus, right? You can be infected. How many people do you know who've been infected 3, 4 times? And their third time being infected might be worse than the earlier ones. Pathogenicity and co-pathogenicity. We don't know exactly what happened in 1918 with the flu virus, but it was able to trigger fatal bronchopneumonias as part of its pathogenicity. So that was one reason why it was so lethal. And then varying pathogenicity. Zika has been around for a long time and never caused any trouble, but all of a sudden in 2015, it seems like it made one single amino acid change in its genetic material, and suddenly it could cause serious illness in families, in kids, in pregnant women, and cause microcephaly in children, and never did that before. So that was a surprise. And then it spread to our neck of the woods, which it hadn't been here either. So these, they're constantly changing. Then just, kind of to wrap that whole section up, is that diseases, including emergent diseases, result from interactions between the infectious agents, hosts, and the environment. So we talked all about what, the infectious agents might do to try to make it so they're more likely to infect new hosts, evade immune systems, cause more serious illness, and so forth. And then The environment, we talked about all the different factors that can change the environment that might make it more likely that the disease exists. And then finally, our own human host, what our behaviors are that may cause us to be more likely to become infected. And then, of course, our innate genetic susceptibility. So then I just wanted to touch a little bit on pandemic preparedness. The US thought we were prepared. CDC's been preparing ever since 1918 for a huge pandemic, right? They have quarantine and isolation stations. They do outbreak response, disease control, identify clusters. The CDC has the ability to enact trade and travel restrictions. They can develop and manufacture diagnostic tests and support research on drugs and vaccines, respond to foodborne infections, go all over the world, have surveillance going on, and also take on antimicrobial drug resistance, as we were saying. So as I was reading this, I've been working in public health for more than 20 years. And I've always been very proud of our public health system, but I have to say, I felt a little bit sad going over all this just because we'll talk a little bit about what happened, but CDC has quarantine stations. There's 20. I was interested to hear we used to have 55, but in 1970, apparently the federal government decided we had conquered infectious diseases, so they were reduced to 10, but then decided maybe 10 wasn't quite enough because they were having disease outbreaks, so they increased it up to 20. Those are the diseases that you can be quarantined for upon entry to the United States. And, novel diseases are on there, severe acute respiratory syndromes. But you can see where they are and the regions that they cover. Lots of federal agencies are responsible for protecting us from pandemics and infectious diseases. Customs, Fish and Wildlife, the Department of Agriculture. It's not CDC alone, of course. And then travel industry, cruise lines, port officials, EMS services, local health departments, state health departments. We're all to work together. And then with our neighboring countries of Canada and Mexico, with their border authorities, the World Health Organization, we're supposed to all work together to be monitoring and to make sure that diseases do not enter into the country. We also have a pretty fantastic laboratory response network, and it starts with Sentinel looking for disease. There's a lot of Sentinel labs that provide samples. So how do we know what strains of flu are circulating every year? It's through those Sentinel labs. How did we find the H1N1 in 2009, the novel H1N1 influenza? It was through the Sentinel labs. We also then have all the way up to our LRN labs, which are the ones that, if you think you might have plague and so forth, they're going to be coming to us, and then we'll be sending it to CDC. But you can see there's quite a few labs, 130 across the nation, that are the LRN, which is the smallest group. And I think there's about 1,300 of the Sentinel labs. So we do have lab capacity to be looking for infectious diseases. There's also the Emerging Infections Program, and I won't belabor all these. And then for global surveillance, the Division of Global Health Protection, they're the ones that when there was Ebola back in 2014 in Africa, they went there, right? They went there to help get the disease under control at the country of origin. And now we have the National Center for Emerging and Zoonotic Infectious Diseases. They're the kind of the science geeky guys that do molecular detection, they're the LRN network, antibiotic resistance, zoonotic diseases, and so on. They're the ones developing new technologies. So we had a system in place that was looking at all different aspects of trying to keep disease from coming into the country before COVID. Okay, here we go with another learning check. Factors that contribute to the emergence of infectious diseases include ecological changes in agricultural development, human demographics and behavior, international commerce and travel, technology and industry, microbial adaptation and change, or all of the above. All of the above. And then true or false, most newly emerging diseases of concern have been caused by viruses which are inherently able to rapidly adapt to ecological niches. True. Yes, 100%. Good. Okay. Then I did want to talk a little bit about recent examples of pandemic infectious diseases and start with the H1N1, novel H1N1 in 2009. And you probably remember, well, what happened was, and this was a great success story, so on April 15th, 2009, a success story of us stopping something and, taking action, I guess I should say. April 15th, a child living in California was in a CDC-sponsored study, actually, for flu, and was found to have an unsubtypable. They didn't know what kind of flu it was, so they had to send that immediately to CDC. And CDC identified a novel swine origin flu. 2 days later, another kid living 130 miles away who had no contact with the first kid was found to have that same influenza strain. And you can see here all the cases there. On the left is the graph that you usually see for flu. It's in the winter time, between October and May. And then suddenly, back in 2009, we had this new strain in April, which is not when you would expect flu to start showing up, and it really took off. I like this graph, this image here, which is from New England Journal of Medicine, that shows that this human-to-human spread of swine influenza virus had been rarely documented. People who have pigs or who go to the state fair and bring their pig, you occasionally hear of them getting swine flu, but it doesn't usually spread human to human. And it had never been known to cause widespread community outbreaks among people before. And we have sequenced samples going back a long time. So what they found from the 2009 H1N1 influenza virus was that it contained gene segments from 4 different influenza virus sources: a North American pig, North American avian, bird, human, and also from a Eurasian pig. So 4 different flu viruses with 1 segment of human in there that made it so that it would be infectious to humans and spread from person to person. You've probably heard, any of you who lived through 2009 influenza pandemic heard that pigs can be pretty easily infected by bird influenza and human influenza, so that they serve as a good vessel, is what they're called, where those can all mix. And we know that all those viral strains are, mutating, and so then they can recombine. So that's what it seemed happened. And we don't know what the mixing vessel is, but we do believe that it was a swine host. So now we have a virus we've never seen before. It's a swine flu virus, and it's spreading from person to person. We never saw that before either. That was kind of concerning. So what did CDC do? Collaborated. They sequenced it. They sent it out to the world right away. World Health Organization by April 25th had said that there better be concerned. This looks bad. Everybody get on the alert. CDC developed an RT-PCR test that became the gold standard for flu testing in the nation. They did that. And then it was, of course, concerning, if you remember, that it was primarily affecting youth. And normally, it's people over the age of 65. And so it was disproportionately affecting those aged 5 to 24 years, and that's where 41% of the hospitalizations were, and actually 80% of the deaths were in people who were under the age of 65, totally opposite of what we see during a normal flu season. So the strategic national stockpile, we're supposed to have a big stockpile that's available, that has ventilators, that has antivirals, it's supposed to have masks and gloves and everything that we need that can be delivered within 48 hours to anywhere in the nation. And that's what was deployed when anthrax happened. So that was used. We knew we weren't going to get a vaccine anytime soon, because egg-based technology. It takes at least 6 months to make a vaccine for influenza. So what the nation did initially was send out supplies from the Strategic National Stockpile to make sure everybody had antiviral medication and had protective equipment and ventilators, so that they would be able to at least take care of people, protect themselves from getting infected, and offer some treatment. And then this, just to show how things can really impact communities. From April 12th, 2009 to April 10th, 2010, CDC thinks that there were 60 million cases, 274,000 hospitalizations, and more than 12,000 deaths from this novel influenza virus. A monovalent vaccine, and when this happened, I was the director of the health department that's in that image there, that map. The village of Skokie, it's just north of Chicago, just west of Evanston, and has a population of 65,000. It has had a health department since the early 1900s. I had a nurse and myself, and that's all the vaccinations that we gave. We had more than 300 medical volunteers help us give 20,000 vaccinations. So just to show, for H1N1, which proved not to be, thank goodness, as lethal as we had thought it might be, it still required tremendous community impact. And monovalent, if you remember, monovalent vaccine was produced because we were already making seasonal vaccine. So it didn't seem like it would make sense to restart that whole 6-month process and add in H1N1. So we made a single monovalent vaccination, but it wasn't available. I watched the ACIP meeting, and all the manufacturers said, for sure, we'll have it by October, by the fall, and we didn't. And that was when the next peak was in October, November. So thank goodness it wasn't more lethal than it was, because otherwise things may not have turned out as they did. In any event, what we did in Skokie, because of the school, we went to all 52 schools and daycares, and then we asked people to come who were in the priority groups, which was young people and people that, up to age 64 who had underlying health conditions. The World Health Organization declared the pandemic over in August of 2010, but of course the virus is still circulating today and causing illness every year today. That was a nightmare. Not having enough vaccine and having clinics scheduled and all that stuff. So, but anyway, fortunately, it was not worse than it was. And overall, to think that we quickly identified it, everyone in the world knew about it. We then made a vaccine as absolutely fast as it could possibly be made, but with technology that required 6 months. Overall, I think that it was a good response. And the communication, CDC did 60 during this year, news press conferences, 60. So then just saying a word about monkeypox. As the other example, on May 13th of last year, the UK was notified the World Health Organization of 3 cases of monkeypox disease from one household, including a British national who came recently from Nigeria, where the disease is endemic. And then on 2 days later, May 15th, 4 additional cases were identified, and they had no known connection to the first group of cases. So we realized that, the public health community realized that there was something of concern. And that map that I have right here is, as of June 6th, all the countries that have had human cases of monkeypox. Blue is where it has been endemic because it's in the monkey population in those areas. And then people come into contact with it. And so it is endemic there, but then all the orange areas are where it had not historically been reported before, with the exception I mentioned in 2003, some pets gave it to some of their family members because the pets had been infected by rodents from Ghana. So it's an orthopox that causes a disease with symptoms similar to smallpox, but less severe. And it's a zoonosis. It had not been known, again, to spread much human to human. It can be spread human to human. You have to have close contact, as we know, but it had not previously It had typically been limited. There had not been substantial. But then unexpectedly now, we suddenly found it spread globally by human-to-human transmission outside of Africa. And it's unclear if this is due to behavioral environmental factors or if the monkeypox virus is adapting to a new host. Interestingly, they have done sequences, gene sequences, and so they're now classifying this as a clade 2B because fortunately it is not very lethal. The clade 1 monkeypox viruses are, but clade 2B, similar to clade 2A, is not as lethal. And but we don't know if that genomic shift has made it more likely to infect people. And then those are typical lesions that you might see on the skin from this disease. So what was the response? On May 17th, Massachusetts Department of Health. So in April, World Health Organization then notified the world, right, that this was out there. And so health departments across the world, whether they had monkeypox cases they knew of or not, started telling everyone, hey, there's this new disease, you better be careful. These are the people who seem to be affected. This is the things that we should be doing. So then in May of 2022, it was not a surprise to find it, we weren't surprised that it ended up in Massachusetts, and they announced that they had the first case from this global outbreak. May 23rd, CDC launched an emergency response. But you can see how quickly it's spreading around the globe. And so what did their response include? Education, surveillance, looking for cases, telling all the doctors what to look for, laboratory testing, and then also having the vaccination and then treatment. With all that, there were 26,000 cases in the United States identified between May and October of 2022. 95% were in cisgender men, 75% had male-to-male sexual contact in the 21 days prior to symptom onset. But by October, the response measures had been highly successful. The concern is that cases are still occurring. Cases are still occurring. And there's a wonderful COCA call, the link is there, that was given on May 18th that you can listen to, where they go into all the treatment regimens and so on, vaccination and so on. But cases can occur in vaccinated individuals, but have not been severe. The majority of people at risk have not gotten vaccinated. There was some shortage of vaccine to begin with, and a lot of people, it's a 2-dose regimen. A lot of people only got that first dose, and they have not gotten both doses. So if really in any areas where you're working, where there are individuals who may not have been vaccinated, that's our public service announcement, is they really need to get vaccinated as the best preventive measure that there is. And then you can see that here. We did have an increase in cases when it first appeared, worked really hard to identify people, make sure they got treated, make sure they got vaccinated. Even after you've been exposed, within 4 days, you can still get vaccinated, and that's thought to prevent you from developing the infection. But then, even though it looks very small there at the end from January of this year, there's still cases, 5, 10, 20, occurring regularly. And so we have to continue to be vigilant and make sure that people are protected. So then just a few concluding thoughts. One thing I wanted on a positive note was there's a lot of work being done on One Health to talk and think about breaking down the silos between human health, animal health, environment, and having all those individuals with expertise working together to have a more healthy relationship with the environment so that it's wildlife isn't displaced and so on. But then thinking about how we can all live more healthily together so that we don't have recurrent outbreaks of infectious diseases. It's not just affecting us, it's affecting the wildlife, it's affecting our crops and so on. And so how this can all work together. So One Health is a really important approach to have entities that maybe weren't talking to each other before. The veterinarians in 1999 noticed there were a lot of reports that crows had died. and that was West Nile virus. But there wasn't a connection made that we're seeing a lot of animals dying. Something might be going on that may impact us as well. And so this is a wonderful program that CDC is spearheading. And then I don't know if you saw this report that came out in December from Congress. It's from Homeland Security and Governmental Affairs. I put out a bunch of slides, but I don't want to end on a depressing note. The end of a great conference. I'd highlighted everything and I was like, oh, I'm not going to traumatize everyone again. If you want to read this and read all about what the findings were, you can. But historically unprepared examination of the federal government's pandemic preparedness and initial COVID-19 response. The problem is we didn't really respond when there were the first cases. We didn't respond in the United States. I remember being at work, I wasn't at the state then, and wondering how come, why aren't we doing anything? How come we're not hearing anything? But we didn't respond. And if you don't do it right away, then as we saw, it can get to be too late. In March, our first case in Skokie where I was working was a homebound man. And so I called the state and said, do you think this is a false positive? Because if this is really our first case, it's everywhere. We're done. This is over. And that was in March 2020 because a homebound man. And of course, our EMS personnel didn't wear protective equipment or anything because we didn't think it was around really much then. And he had fallen, but then it turned out he had COVID. He was, at some point, people noticed he was coughing a lot, et cetera, et cetera. So anyway, COVID pandemic has devastated communities in the United States and across the globe. Many of these deaths and much of the economic fallout could have been prevented. Although the federal government has prepared for public health threats for decades, these actions proved insufficient for COVID-19. The strategic national stockpile was not replenished after that 2009 deployment for the H1N1 influenza pandemic. We didn't fill it back up again, ever, in that 10 years. The federal government had no insight into how anything was made, medical supplies, where they came from, what was, where they were used, and so on. I was shocked to read that the CDC and Department of Defense first learned out about the COVID virus from publicly available postings. Doesn't seem like very good surveillance and so on. So there's a lot in there and we've all lived through it. So I would recommend reading it, at least looking at the executive summary, and you're going to say yes, 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 as you go down it. And then the CDC, to their credit, under Director Walensky, did their own internal review. Things like, we're too academic. We take too long to get guidance out. We put guidance out that people don't really understand what we mean because we wrote it in a way that's not easily digestible and it's confusing to people and so on. So they looked at their structure, that they weren't set up to really effectively respond, basically. So a lot of changes and everything out of date, all of the technology and so forth. The private sector is way ahead of where governments are. Even healthcare is way ahead of where governments are. They talked about how in Alaska they were faxing reports, of COVID. So at the beginning. And so we need to have data modernization. That's underway. We need to have, expanded laboratory capacity. CDC had made a great test for the H1N1, but they weren't able to do it this time. And there was too much hesitation to use the private sector to get a test. We didn't have testing, we all know, we lived it. So not to review everything again. And then to have people who are trained who can respond. Now, of course, the CDC has been terribly underfunded, as health departments have all around the nation, and have lost a lot of people actually since the economic downturn in 2008. Our, local public health departments have been decimated, but so it's not completely, like they were asleep at the wheel and didn't, not doing their jobs, but we do need to make a lot of work. So If you would like, you can read that too. Like I said, I had a few slides highlighting all that, but decided not to end the day on that. So here's our last two questions. True or false? The 2009 novel influenza A H1N1, 2019 SARS-CoV-2, and 2022 monkeypox pandemics involved viruses with an animal origin. True or false? True. And then the One Health framework is a helpful approach to reducing the risk of infectious disease outbreaks. True. Okay, and then I have a bunch of quite a few references in here. There's a lot of work being done on this area. So I think we have a couple of minutes if people want to, I don't know if anyone wants to share your own experiences or thoughts, or if you have any questions. That was all that I wanted to share. It was kind of cathartic for me. Thanks for listening to me. We've all been through a lot. Anybody have any thoughts you want to share? You're all part of the solution too. And I want to thank you again for hanging in there during this whole pandemic and for all the work you do every day, whatever setting that you're in. We appreciate you and couldn't have gotten through the pandemic without you, and look forward to working with you again in the future. Oh, question.
I have a question for you, because I think it's an interesting conversation that circulates. And so with the very limited ability to test for COVID in the beginning by meeting certain qualifications, and that testing was just not available.
Right.
So you had to do that dance to get somebody tested in the first 6 to 10 weeks. Your opinion, do you believe, and I have my own opinion, but what is your opinion about, could it have been here and circulating much earlier than
Yes.
the first cases that were?
So her question was, since we weren't able to test anyone hardly at all at the beginning, could it have been circulating? Yes. And that just emphasizes how, you know, in the other two instances I presented, monkeypox and influenza, we did get testing right away. We got reports out, we got on it, you know, there were press conferences and all of that, and that didn't happen. That didn't happen. Of course, we're in the trenches. We don't know that this is going on, really. And so, yes, that was my example from in the town. I was the health director, and our first case being a homebound said to me, we're in trouble, you know, right then. And that was like March 17th or something like that. So
Early February, we had an outbreak of a respiratory virus that wasn't influenza A, wasn't influenza B, wasn't RSV. It presented like, you know,
Yeah.
looking back.
yeah, so she's relating, where do you work?
I was in Peoria. at the time.
Peoria, okay. So they had a outbreak of respiratory illness, not influenza A, not influenza B, not a RSV. What do you think? Yeah. Yeah, I mean, clearly it was, when you see all the other countries with the huge number of cases in the US had that one little dot in Illinois, I think, because we had in March, beginning of March, seems unlikely with all the people who come here.
So my last question to you specifically.
Sure.
So New York, the way they were hit, you know, with such large numbers, with very disseminated disease, what is your opinion on why that happened there? And as it spread, it became less so. So like when Europe had it, so I had friends who went to work out there, and it was just case after case of disseminated severe COVID. So
are you
I
asking?
guess I'm asking you, and from your experience, what you think, why did it so rapidly change from such a death sentence in New York to
Right.
where it then began to spread?
Right. It did, you know, over time, it did change, but it was pretty severe no matter where it went in the United States at the beginning.
In Michigan, they didn't do the same thing as the plane. They actually put the COVID patient into the line. And we wiped out an entire population by doing that. And I can tell you, I have, from the crisis team, you still have people who have PTSD.
Oh, yeah.
What happened
We all
there.
do.
So I think that with you're gonna see the population being much larger, but there was just as much stuff happening.
Was that
And more
Delta? Was that the
concentrated.
Delta? Was that considered the
Well, it
Delta?
was the initial one, and then I'm blanking on what it was called, and then we had Delta after that, and then finally we got to Omicron. But then thankfully, we got vaccine, because otherwise we would have been in a really bad way if we hadn't gotten that and gotten that out. So that was bright point, right? That we already had technology, the mRNA technology had been developed before to make for vaccines. So they tried it to see if it would work for this, and it did. But anybody else? Yes.
Dr. Counard, do you know if the combo COVID-19 and flu vaccine will be available this time?
I haven't heard that it will be, but I know that's a goal. Good question. We will have a combined. I have not heard that that's going to be available this fall, but I know that's underway to have that, and that'll be an annual. Yes. Oh, sorry. Go ahead. Yes.
I was just gonna ask, in the same area on vaccination, I know that they now came out with like vaccinations are mandated for healthcare facilities. However, that being said, are they gonna eventually do what they do with the flu, that we have to meet a certain percentage of vaccination in order to get funding?
We probably, I don't work for CMS, so I just try to read what they put out and help you guys understand what it means. No, I would imagine that's probably at some point going to come down. Yeah, they've moved now to educate and offer and not have that initial requirement. And then did somebody else? You have a question? Yes.
So I don't know if it was like a few months ago about the Detroit case. I don't know if it was Detroit or if it was in Ohio, but there was the kid that was, I don't know if it was K-5 that expired due to an intestinal disease that's unknown. And I guess they were saying that the next pandemic could be possibly gastrointestinal related. And so
Sure.
I guess my question is, when we talk about all these other things of these animals, but most of the stuff is respiratory versus
Right.
gastrointestinal, that's a whole different ballpark of how to handle it. I mean, we can barely keep C. diff down. So I'm just curious, like, what other, IP, things that will create,
Oh, sure.
that type of.
You're right. Gastrointestinal could be another big, when you think of people who die of Ebola, they are profusely vomiting and having profuse diarrhea, profuse. And that's, one drop gets in somebody's eye and that's how it spreads. So think about all the norovirus. How hard is that to contain, So you're right. That could be another route. One of the things I thought Dr. Fauci mentioned is he said we get this idea that diseases are all we're going to become acclimated and they're going to become milder, but that doesn't necessarily happen. They may evolve to do just like you said, contaminate the whole environment because someone's been vomiting uncontrollably. With noro, somebody might go to a restaurant and they become ill. You got to think they weren't feeling ill when they went there. Kids throw up in the hall, at high school and so on. It just comes on you like that. So yeah, I think you're right. That's certainly another mechanism. Respiratory, especially like with that SARS, initial SARS in 2003 that went to Toronto. If you remember, Toronto was on quarantine, and they did a great job. It was only controlled within public health infection, quarantine and isolation, but it spread through the ventilation system at that hotel. So respiratory still can cause quite a bit of disease. So, but absolutely, there's multiple routes. If you have to have actually skin to skin contact, that's probably going to be a little more contained. But the vectors, how many people die of malaria every year? That's one of the top killers of the world. So, gosh, I wanted to end on a positive note. Anybody, did I see any other hands, or everybody's ready to go home for the day? Well, I really appreciate you coming, and I'll be here for a few minutes if anybody has any other burning things you want to talk about. And have a great rest of your day.